So let us start respiratory pathology. Now pathology, first of all, I will talk about rhinosinusitis. It is nothing but the obstruction of sinus drainage into the nasal cavity. Inflammation and pain over the affected area typically affects the maxillary sinus. Why? Because it's drain against the gravity due to ostia located in the superomedially. Red arrow in the red arrow points to the fluid filled right maxillary sinus. Okay, so here you can see red arrow is pointing towards the fluid filled right maxillary sinus. Okay, this one, this thing over here. Okay, sorry, you see. So superior meatus drains sphenoid and posterior ethmoid. How would you remember this? See, the first and third letter S is P, superior and posterior ethmoid. Remember that, okay? And the inferior will drain the nasolacrimal duct, and all other things, that is frontal, maxillary, and anterior ethmoid. These three things will be drained by the middle meatus. Okay, so how to remember? In the middle, you put your family. So F frontal, M for maxillary, A for anterior ethmoidal. Most common acute cause is viral upper respiratory tract infection, may lead to superimposed bacterial infection, most commonly Streptococcus pneumoniae, Haemophilus influenza, and M. catarrhalis. Infection in sphenoid or ethmoid sinus may extend to the cavernous sinus and cause complication, that is cavernous sinus syndrome. Okay, just imagine you are seeing in the cave. So S and E, that is sphenoid and ethmoid, can lead to the cavernous sinus syndrome. Okay, now talking about this topic, epistaxis. Epistaxis is the fancy name for nosebleed. Most commonly occurs in the anterior segment of nostril, that is Kieselbeck's plexus. Life-threatening hemorrhage occurs in the posterior segment via the sphenopalatine arteries, a branch of maxillary artery. So they might ask you that there is a posterior hemorrhage, what was the branch? So you need to take the maxillary artery, okay, which is again the branch of external carotid artery, if you remember. Common cause include foreign body trauma, allergic rhinitis, and nasal angiofibroma, which is most common in the adolescent male. Kieselbeck drives his lexus with his legs. So what are the blood vessel involved in the Kieselbeck? It's remembered by the legs. Okay, so labial artery, okay, anterior and posterior both ethmoidal artery, and greater palatine arteries and sphenopalatine artery. Okay, so kiss the legs. Just imagine just imagine you are kissing the legs, okay, to remember the arteries. Okay, so labial artery, ethmoidal, both ethmoidal artery, greater palatine artery, and sphenopalatine artery. Okay, now let's talk about the head and neck cancer, mostly squamous cell carcinoma. Okay, remember this. Okay, head and neck cancer, mostly squamous cell carcinoma. Also it is in the cervix. Okay, cervix also there is squamous cell carcinoma, most common. Risk factor include tobacco, alcohol, and human papilloma virus 16. Okay, oropharyngeal, EBV in nasopharyngeal. Okay, Epstein-Barr virus is involved in nasopharyngeal cancer. Field cancerization, carcinogen damage wide mucosal area, multiple tumors that develop independently after exposure. Now let us talk about the DBT. Okay, this is a deep vein thrombosis. DBT, blood clot, as the name suggests, in the deep vein, swelling, redness, warmth, pain. Okay, there can be swelling, there can be redness, warmth, and pain. Predisposed to vasotract, that is stasis, hypercoagulability, and endothelial damage. Stasis can be due to post-op or long drive or flight. There will be classic history of these things. Defect in coagulation cascade proteins such as factor V Leiden, oral contraceptive use, pregnancy. Endothelial damage, exposed collagen triggers the clotting cascade. D-dimer lab test used clinically to rule out DBT in low to moderate risk patient, high sensitivity but low specificity. So basically you can do it for the screening test. Okay, D-dimer lab test. Okay, so it's highly sensitive test. Most pulmonary emboli arise from the proximal veins of the lower extremities. Okay, use unfractionated heparin or low molecular weight heparin, example enoxaparin, for prophylaxis and acute management. Both prophylaxis and acute management use heparin or enoxaparin. Use oral anticoagulant, example warfarin or rivorexaban, for treatment. Okay, that is long-term prevention. Imaging test of choice is compression ultrasound with Doppler. Okay. Some more thing that I have added here is Kieselbach plexus bleeding is anterior. Compression of nasal alveoli will help in the elevation and vascular watershed areas of the nasal septum. This is the vascular watershed area of the nasal septum. Okay, remember this is a septal bleeding. Laryngomalacia, there is inspiratory stridor during infancy due to collapsing of the supraglottic. This is very important. Okay, so supraglottic stricture is formed in the laryngomalacia, but in the subglottic narrowing is seen in the steeple sign of, yes, laryngotracheobronchitis, okay, caused by parainfluenza virus. So choanal atresia, congenital obstruction, bilateral choanal atresia, upper airway obstruction, and cyanosis with feeding but not excessive drooling. Now talking about nasopharyngeal carcinoma, there will be history of southern China, genetic dietary factors, for example salted fish. Okay, salted fish is notorious for it. Pre-malignant nasopharyngeal epithelial lesion, subsequent malignant transformation induced by Epstein-Barr virus. So not only remember Epstein-Barr virus but also salted fish consumption in the southern China, which is responsible for the nasopharyngeal carcinoma. So that is why there will be classic history from us patient from the Chinese origin. Okay, Chinese descent people, because they have a very, they have a genetic predisposition and also their dietary culture, salted fish, leading to the pre-malignant condition of the lesion. Now quickly talking about the pulmonary embolism. Risk can be greatly reduced by administration of a prophylactic anticoagulant, low molecular weight heparin, enoxaparin. Okay, VQ mismatch, hypoxia, and respiratory alkalosis. Remember, this is very important. Okay, respiratory alkalosis. Why? Because in the embolus, because the blood is not getting enough oxygen, there will be hyperventilation, and that hyperventilation will wash out all the carbon dioxide, leading to respiratory alkalosis. Sudden onset dyspnea, pleuritic chest pain, tachycardia, and tachypnea. Large emboli or saddle embolus may cause sudden death due to electromechanical dissociation, pulseless electrical activity. CT pulmonary angiography is imaging testing of choice for PE. Look for the filling defects. May have S1Q3 T3 abnormality on ECG. Line of Zan are interdigiting area of pink, platelet and fibrin, and red found only in the thrombi formed before death. Okay, so pre-mortem thrombus. Here distinguish pre and post-mortem thrombi. Types: air emboli, fat emboli, thrombus, bacteria, amniotic fluid, tumor. An embolus moves like a fat bat. Okay, this is just a mnemonic to remember all these things. I think that is not that necessary, because you can. In fat emboli, what happens? There will be thrombocytopenia and anemia. RBC lysis, and pulmonary hemorrhage. So here you can see in fat emboli associated with long bone fracture and liposuction, okay, to reduce weight. Classic triad of hypoxemia, neurological abnormalities, and petechial rash. Okay. In osmium tetroxide stain, there will be black staining. Okay, osmium tetroxide. Air emboli, nitrogen bubbles precipitate in ascending divers. Caesium disease or decompression sickness, treat with hyperbaric oxygen, or can be iatrogenic secondary to invasive process, for example central line placement. So there you will see, you'll find a classic finding of crepitus. Okay, microvascular occlusion in the cerebral white matter or brainstem or spinal cord can lead to this neurological finding found in the fat emboli. Okay, now talking about the amniotic fluid emboli, typically occurs during labor or postpartum, but can be due to uterine trauma, can lead to DIC, rare but high mortality. Okay, so this is a risk factor for DIC. Other two diseases that I just want to recall you is that also in the AML, okay, APML, there is DIC, and also in the abruptio placenta there is DIC. Okay, now talking about these things, this is very easy actually. You see, everything decreases in the restrictive pattern. Only the thing that increase or is normal is FeV1 by FVC ratio. But here you can see that residual volume and functional residual capacity increases in this case, which lead to the increase in total lung capacity. But FeV1 by FVC ratio is decreased, but the numerator is so much in decrease compared to the FVC. That's why the FeV1 by FVC ratio is decreased in case of obstructive lung disease. Okay, FeV1 decreases more than FVC. Okay, remember this. Now, in this loop you can see whenever the long volume, okay, this is the inspiration, sorry, this is the expiration, the above one is the expiration and this is the inspiration, okay. So whenever the this graph, okay, shift towards the higher volume side, okay, higher volume side, that is for the obstructive disease. But if it shifts to the lower volume side, it is restrictive disease. And there is one more extra thing given in the tracheal stenosis, and that is more like this green circle, okay. So there is not much shift in the tracheal stenosis, okay, compared to the normal. Simply there is the flow that is during the expiration becomes more uniform, okay, like more equal, nearly like the inspiration, okay, nearly like the inspiration. Expiration and inspiration pattern will be same, unlike the normal one where the expiration was in this way and the inspiration was in this way, okay. Remember that this is a very easy way to quickly get to the answer. Okay, we will meet in the next section.